Today's forum is given by John, and he's going to tell us all about AI in radiology, and particularly his NHS fellowship in clinical. I'm just speaking slowly so these guys can get some pizza, and then we can let John tell us all about it. Is anybody online? Probably 16 online. Well, good evening, those of you who don't want any pizza. So, John, take it away.
Thank you. So, thanks, Martin, and also thanks to Ferrier and Chris for inviting me to speak this afternoon. So, for anyone who doesn't know me, my name is Chen. I'm a specialty registrar in radiology here at Cambridge, subspecializing in neuroradiology. And today I'd like to talk about, give a brief introduction to artificial intelligence in radiology, because this is of increasing importance to our field, and also a bit about the NHS Fellowship in Clinical AI, which is a program that I'm doing this year, and which some registrars might be interested in for the future. Okay. So the aim of today is just to give a brief overview of artificial intelligence radiology and the fellowship, aiming to address some broad questions such as what is AI, how does it work, what are its applications in our field, what might be its impact on the practice and profession of radiology, and why should we engage, and also a bit about the fellowship, what does it involve, how to apply for it, and broadly what work is taking place at our institution. So just to start off with some terminology and definition. So when people think of the term artificial intelligence, most people think of, very advanced modern technology. But to be honest, these three terms, artificial intelligence, machine learning, deep learning, are often conflated with each other. Artificial intelligence is actually a very broad term that ultimately just means anything man-made that has any semblance of human intelligence. So you could argue that a standard computer, or even a calculator, or I would argue even perhaps a printed book, has some form of artificial intelligence by virtue of having, for example, recorded information paralleling human memory. Within AI, a subset of this is machine learning, which describes algorithms that are able to learn from data and improve with experience to do tasks that they do not only consist of explicitly programmed abilities, but they have the ability to learn further. And further subset within that is deep learning, which is a powerful type of machine learning built on multiple layers, a multi-layered neural network that is able to kind of perform quite complex tasks and process quite large amounts of data. So machine learning itself can be done by several broad categories of methods. One of these is supervised learning, where you give the model labeled data, for example, images with a label of what diagnosis is attached to those images. And it is able to learn that way and eventually, for example, classify future unseen images. There's also unsupervised learning, which is when you don't provide the labels, you provide it only with, for example, images unlabeled, and it is able to itself learn characteristics of that data and, for example, begin to cluster the population according to those characteristics. And finally, reinforcement learning, where you give a task to the algorithm and there's an error signal, and it tries to minimize that error and it iteratively become better at performing that task. So the subset deep learning we'll talk about is built upon multiple layers of this. And the fundamental unit of processing is the artificial neuron, which is modeled on the biological neuron. So this unit has multiple inputs weighted differently, and a function that produces an output from this. And when you build many of these together onto a multi-layered network, it has the capacity to process very complex data and perform very complex functions. So there is a long history of mathematical statistical reasoning including some major figures that you'll have heard of, such as Alan Turing and Geoffrey Hinton. And the field of modern AI really kind of began in the 1940s, 1950s, and has taken off more in recent years due to advances in computational power and the availability of data. So much so that nowadays AI is often heralded as the fourth great industrial revolution, following on from steam, electricity, and computation, and its potential ability to power the industry. And much has been speculated about the future of AI. So different types of AI. So we often talk about artificial narrow intelligence, which is AI designed to perform specific tasks. But also soon coming may be artificial general intelligence, which may match human intelligence across a wide array of domains. And maybe one day even artificial superintelligence, which is AI that's vastly surpasses human abilities. And once we reach the stage where AI is able to produce or improve upon its own algorithms, we may reach a point which some have described as the technological singularity, which is where AI capability may rapidly explode, and the future will be difficult to predict, with potential far-reaching implications on society. So back to the present, what are some potential applications of AI? So multiple industries can be affected or can make use of AI, and AI is able to be applied to a number of different generic types of tasks. Within healthcare, we obviously think about medical imaging that consists ultimately not only of radiology, but allied imaging specialties such as pathology or dermatology. But really it has potential applications across the whole healthcare domain. And it's important not to neglect the potential utility in areas such as operations and management. So, for example, if your aim is to save costs in the NHS, applications on improving the efficiency of writing discharge summaries or clinical coding might actually have a far greater impact on the entire system as a whole than targeted applications in interpreting imaging, for example. Within imaging itself, there are a number of tasks that AI can perform, such as the detection of abnormalities, characterization, for example, segmenting the area of abnormality, and monitoring over time. And again, this is set within a wider workflow from the acquisition of the images to reporting. And even sort of more generally than that, the whole cycle of the radiology process, from requesting a scan to the scan happening, reporting it, and communicating back to the referring clinician and patient. All of these are potential areas where AI could have an impact in improving. And again, it's not necessarily the interpreting part that may be most of value. It could be, for example, workflow prioritization that could have a greater impact. So it's important to think about all the various areas in which AI could have value in our workflow. Some examples within image interpretation itself include brainomics technology, which we do have here at CUH for the use in stroke. Analyse AI, which looks at chest X-rays and CT heads, and this tool CoreLine for looking at pulmonary nodules, which we may procure and deploy in the future. So there's been a massive proliferation of AI products in recent years. So if you go to a radiology conference, there will be dozens of vendors of AI products, and there are now hundreds of approved products and companies marketing these, approved in the EU and in the US. And this website, the Radiology Health AI Register, lists many of these. So is it the case that we now have all these available tools and they will revolutionize our practice? Well, first of all, we can't use hundreds of these tools. We do not have the resources to procure all of these and then put them all in our department. So the first step is to think about our departmental priorities. So what sort of AI application would be most useful, would help our clinical workflow the most, and what should we be targeting our efforts towards? So Tatiana, one of the registrars, and Philip, one of the consultants, along with the AI imaging group, sent out a survey to the imaging department, which many of you may have completed, asking what are the departments, what do we feel are the department's priorities in AI, and the highest kind of the most voted areas are workflow optimization and image quality enhancement. So again, not necessarily image interpretation itself. So having identified kind of our target areas, is it straightforward to gain the benefits from AI in these areas? So again, not necessarily. So even though there are many benefits and opportunities provided by AI, there are also numerous risks and challenges in these different categories. So for example, technical limitations. The AI, its performance may be limited. It may produce errors. Those could result in clinical harm. That is an issue. AI algorithmic bias. So AI is trained on certain, large training sets of data on a particular patient demographic. When you apply that to a different demographic, it may perform worse. It may reveal some social demographic biases that could result in harm to certain parts of the population. So there's issues of fairness there. So AI uses large amounts of personal health data, and there are concerns over data privacy and public trust in giving this data to technology companies. There's issues of over or under reliance on AI when we're interacting with it. I'll speak more about that later, along with workforce implications later. And furthermore, there's some regulatory and legal challenges. So apart from requiring, legal approval for all of these, there are risks that radiologists may end up as liability sinks for AI. So you end up taking all of the liability when you use this product. So most companies will not agree to take liability for their product. It will be on the radiologist to use it appropriately. And ultimately, the liability will lie with us. So that presents some issues. In some way, it exacerbates the issue compared to not having the AI product. So once you have the AI product, if the AI is wrong and you report according to that, you're still liable for that. If the AI is right and you report different, and you may have good reasons for doing so, eventually people may look at this in court and say, the AI has said this, why have you said different? So in some way it compounds the risk of liability. So these are some potential issues there. And so for these reasons, the potential of AI in healthcare is not yet fully actualized. So there are a number of risks associated, and there are also some challenges of implementing. For example, insufficient evidence for clinical and particularly for cost effectiveness, difficulty integrating into the IT systems and clinical pathways, particularly within the NHS. Sometimes they have quite outdated IT systems. Throughout the NHS, we often have significant organizational and financial constraints, and there is a need for local resources and local expertise in this area. And so all of this results in an implementation gap, and bridging these requires some, expertise and leadership in the clinical AI domain. So this brings me to the NHS Fellowship in Clinical AI, which is a national program aimed to develop skills in clinicians in implementing AI in the NHS. So it's based at the Clinical Scientific Computing section of Gladstone St Thomas's Hospital, but it's a national program, and was initially brought about following some national reviews on the future of healthcare in the UK. You may have heard of the Topol review led by Eric Topol. And the program aims to give fellows experience in a real-world application of clinical AI under the supervision of an expert AI supervisor and surrounding team. There's an overarching teaching program covering different areas of healthcare AI, and you become part of a network of alumni of this program. So just a little bit about the program itself, because it may be of interest to registrars in the future. It's recruited competitively across the NHS, so both medical and non-medical staff across multiple regions, including here at Cambridge, where clinical applicants will need to be ST3 or above at the time of starting the fellowship. These are the faculty leaders of the fellowship, and you can get in touch with them if you have any questions. The application process normally begins towards the end of the calendar year, and you need approval from educational supervisor and training program director. And they run a webinar each year with some information about it. The program itself lasts for 12 months and is 40% alongside 60% clinical work, and comprises several components, including project work alongside several educational components, so workshops and self-directed learning modules. And this aims to cover the whole AI life cycle, from use case development and design of models to kind of deployment, validation, and monitoring. And it also aims to cover a bespoke curriculum covering multiple themes relevant to clinical. So technical fundamentals, regulation standards, validation and evaluation, integration systems, impact and strategy and culture. And from this, you can see that the aim of this program is not primarily to develop technical skills. So by that, I mean programming skills in developing your own AI models, because it's recognized that as clinicians, that will never be your primary value. You'll never have as much expertise in that area as dedicated computer scientists. So it's the aim is to give you a broad skill set across all of these themes that may affect the actual implementation of AI in the clinical setting. And that's delivered by a mixture of didactic and self-directed learning activities. So the project component, the project is assigned to you upon appointment and aims to give you experience in deploying and validating AI solutions in the clinical setting. So my project is under the supervision of Philip, consultant here in the imaging AI lead, and within the AI and imaging group, multidisciplinary team, which consists of registrars and consultants, academics and operations staff. And the main aims of my project were to evaluate the real-world clinical impact of commercial imaging AI products, and also to develop a pragmatic framework for doing this in general. And if we think about, a summary of the AI process, we can sort of simplify it into, you have a use case, you start with technical development, and eventually you deploy this clinically, and underpinning all of this are regulatory and policy elements. So I'll try to touch on some of these areas. So just to give a brief overview of some of the work that we've been doing. In the domain of clinical deployment and evaluation, we've been looking at this tool called Pixel, which is a recently deployed in our department for detecting and characterizing multiple sclerosis lesions on MRI brains. So these patients are typically monitored with serial MRI studies to look for enlarging or new lesions, which may signify active disease. And this task can, if there are numerous, say hundreds of lesions in the brain, this task can be fairly challenging and time-consuming to do accurately as a human reader. So this tool can detect lesions, compare to previous studies, and classify these lesions as stable, enlarging, or new. And it does this by outlining these in blue, yellow, or red, depending on the category. And it aims to enhance our reporting accuracy and efficiency. So we performed a retrospective review of several months' worth of data, 43 cases, and looked at the performance of this tool at different levels. So first at the lesion level, that is how well it performs at detecting and classifying individual lesions, and also at the case level, so taking any new lesion to indicate active disease for that patient, how accurately the ultimate results will mean for the patient. And we found that it's able to detect a lot of lesions. It's very sensitive in lesion detection, but not so specific. So of the new lesions that it detected, about 60% were correctly identified, but about 40% were false positives. And in some patients, this would have resulted, if we had taken that result without changing it, this would have meant they would be erroneously classified as having active disease. Despite being quite sensitive, it did occasionally fail to identify new lesions, and that in one patient would have affected their case classification. But it did identify one new lesion that wasn't detected by neuroradiologists. So overall, our view on this is that it's reasonably promising for identifying new lesions or confirming those lesions, and at the case level, it has quite good performance overall. However, it does occasionally produce false results at both the lesion and at the case level, and careful radiologist scrutiny is still necessary. So this work was done in conjunction with Samir and several other colleagues, and we presented this at the RCI NHS AI meeting several months ago. So we're doing some ongoing work in this area and some planned future work. So a prospective study comparing Pixel alone versus the radiologist alone versus the radiologist assisted by the AI tool. Pre-implementation and post-implementation surveys to gain kind of understanding of attitudes and perceived utilities and drawbacks of the tool. And we're looking in the future to have a look at the potential impact of this on reporting efficiency and any potential impact on clinical. Besides Pixel, there are a number of further tools that are going to or planned to be deployed in our clinical department. So IQMS for the same function, several tools for detecting and characterizing pulmonary nodules from CT thorax studies, Annalise for looking at findings from CT head, and a number of AI platforms, which are basically programs onto which you can deploy individual AI solutions to avoid having the technical troubles of integrating the IT of each solution by itself into the NHS IT. Besides, in evaluating individual tools, we felt that it was important to develop a more general framework for doing this overall for any future tool. And this is underpinned by kind of the logic that we think local evaluation is quite important to ensure safe and effective implementation of AI tools. So vendor claims about performance might not translate to reality. Often AI tools are trained on very enriched data sets, so where the pathology it purports to detect is at a different frequency compared to in the actual population. It's trained on a different demographic. It might be trained on different scanners to where it will be used. And these can all have an impact on its performance, which can vary widely between what is claimed and what you actually find. So I think local evaluation is important. And so we've been drawing up this generic framework along with an abbreviated checklist with key requirements to help us do this for any future tools. And this is informed by existing guidelines from radiological societies and other published literature, such as the radar kind of system framework. So what we've kind of realized is that evaluation spans much more than just the technical. So obviously we have the technical domain in the middle, looking at processing performance of the tool and the diagnostic accuracy of the tool. But there are a lot of other important factors. For example, on the strategic level, what is the clinical application this is used for? Do we have appropriate stakeholder engagement, legal requirements, implementation considerations? Can this be successfully integrated with our IT systems and our clinical workflow? How does this impact the system reporting efficiency? How does this impact, ultimately the clinical outcome? Is this cost effective? And it's important to realize that even if a tool performs very well on the technical domain alone, it might be completely useless if it fails any one or multiple of these other areas. So it might perform very well technically for something that's clinically not very useful. It might perform very well technically on something that ultimately, after a chain of events, doesn't actually impact any clinical outcome at all. It might be far too expensive to procure compared to not using it. So there are all these considerations that are actually very important. And I'll skip over these in the interest of time, but it's important to have appropriate study design and appropriate metrics for what you're trying to develop. So besides the project given to you, there's also scope for spending some time on other areas in the program that you're interested in. So I've been doing some work along with Abby, clinical lecturer, several other colleagues, on a systematic review and meta-analysis of the detection of large vessel occlusion on CT angiography for acute stroke. Obviously, early detection is important because it enables early thrombectomy, which is known to be a very effective treatment for this condition. So we looked at multiple commercial tools over the years. There are a fair number of studies kind of looking at the performance of these. And overall, our results were different studies reported a wide range of different performance for each. But ultimately, overall, the performance seems to be inadequate. So the sensitivity hovers around 0.8. There's a reasonable false positive rate. That means that used in practice by itself, it would fail to detect a fair number of large vessel occlusions. And the ones that it detects, a number of those will be false. So kind of this does raise questions about how useful this is at the moment at its current performance in clinical practice, particularly in a large tertiary centre when you have consultant neuroradiologists, and these are reported reasonably quickly. So I think in the future, we'll need to do some comparative studies on the same data sets to find out, the true performance of these and some reasons behind their difference. Also been doing a bit of work on the technical development of AI models. So in conjunction with several other registrars and in collaboration with Jude, one of the consultants, and several members of the mathematics department, who are looking at developing a multimodal AI tool looking at chest X-rays and combining clinical contexts. So that involved annotating a large number of X-ray images with relevant findings. And finally, speaking about the regulatory and policy elements of AI, I was privileged to attend an international symposium on ethics and global health in relation to AI, with the aim of promoting safe and equitable development. So there are a number of complex barriers to deriving global health benefits from AI, including, in many places, poor data infrastructure, evidence, limited public trust, and regulatory challenges. And whilst AI promises to bring benefit, if that's applied differentially across the globe or across societies, it does risk also exacerbating social inequality in healthcare. So the aim of this is to try to find policy ways of ensuring that AI serves as a force for health equity rather than widening disparities. And we've drawn up a consensus paper that's currently under review that aims to help with this. So besides the work that I've been doing, what else is happening in the department? So in the clinical department, we've got some existing tools and we've mentioned some upcoming tools that will at some point be deployed and will need evaluating. The academic department, there's a lot more involvement in the development of AI tools, both within our department here and in collaboration with other departments in the university, including the mathematics departments. And a number of consultants and academics are doing research or clinical work, clinical research work in AI, so including Tilok, Jude, Alana, Martin, Fiona, and many others. There are a number of meetings, internal and external, on the topic of clinical AI here. So we've got the CUH AI and Imaging Group, which focuses more on the operational side of clinical AI, prioritization and deployment. The academic department, well, a joint meeting we've got focused more on research, also monthly, where each time we'll have one research presentation and one journal presentation, and which any of you are welcome to contribute to if interested in the future. And a number of external meetings where AI now features heavily each year. Besides these, if anyone is interested in finding out more about clinical AI, there are a number of resources across different websites, for example, the Royal College websites, and a number of courses that are available in this area. So I'd like to spend the final few minutes kind of exploring a little bit about what the current and future impact AI will have on the practice and the profession of radiology. So starting with the practical side, AI is now increasingly entering the clinical workflow. So the RCR has an AI registry, which aims to capture the deployment of AI across the country. It's probably out of date, but you can see that there are a number of sites now across the country that are deploying across a number of modalities and subspecialty areas. And this will rapidly increase in the future. As mentioned, there are a number of benefits that we might expect to gain from AI, including improved accuracy, efficiency, potentially improved clinical outcome, cost saving. Besides these, there might be some future benefits and opportunities. So AI may help with the development of radiomics and quantitative imaging. One day we might be able to integrate multimodal information, that is, for example, genomic information, clinical information, and imaging information to help our diagnosis. And one day have personalized medicine, and AI may assist with that. As mentioned, however, there are a number of risks involved, errors, clinical harm, bias, cost, and even inefficiencies. So if AI doesn't perform that well, if we have to spend a lot of time reviewing the AI results, lots of false positive results, we might end up spending more time reporting each scan than without the existence of it. So that is a potential risk. And I think in dealing with this, the overall strategy should be that we find the applications with what we think are have the highest clinical utility and value, and focus on those, whilst understanding their use cases and limitations and ensuring that they're adequately validated. There are a number of recent results that cast controversy on how we use AI in the future. So it's commonly assumed that radiologists with the assistance of AI would perform better than AI alone or radiologists alone. But a number of recent results from studies kind of summarized by Tockel and Redberger have now indicated that often AI alone performs better than the radiologists with AI. So we'll explore a bit about why that is in the next few slides, but this may have significant implications on how we collaborate with AI and what tasks we decide to delegate to AI or not. So this result has been found not only in radiology, but a number of different fields where it's been shown that, you know, human with AI often does not perform as well as either human alone or AI alone. And if we think about why that might be, we can think about a number of biases that might be at play when we interact with AI. So, for example, if we over-rely on AI, we might have something called automation bias, where we trust AI more than we should. We think it's more accurate than it should, and that can lead to lower overall combined performance of the human AI system. Alternatively, the opposite, when we distrust AI, when we accept the outcome of AI less than we should, we underestimate the accuracy of the AI. This is termed something called algorithmic aversion, and that can also degrade the performance of the human AI system. And ultimately, we'll probably have to just be aware that, you know, human intelligence and artificial intelligence might be different. They might be overlapping, but have some different elements. So there might be areas in which AI will simply perform better than humans and might be in the future be proven reliably to do so. There might be areas where humans will always perform better than AI, and there might be areas in which humans combined with AI perform the best. So in the future, we might need to identify what falls into each of these categories and delegate clinical tasks appropriately according to these. So beyond the practical implications on radiology, what are some potential professional implications in radiology? A question on the minds of many is, you know, will AI or could AI ever replace radiologists? And there's been no shortage of headlines about the demise of radiology. So obviously I can't predict the future, no one can, but I can introduce some different perspectives for you to make your own mind up. But all of these do kind of tend in one particular direction. So the first is the technical perspective, and by that I mean from the perspective of the technical capabilities of image interpreting AI alone. And from this perspective, you might think, yes, there's now this infamous quote from Jeffrey Hinton: people should stop training radiologists now. It's just completely obvious that within 5 years, deep learning is going to do better than radiologists. From AI researcher Jeffrey Hinton. So he's not just any AI researcher. He's considered the godfather of AI and won the Nobel Prize in physics for his work in this field. So he said that in 2016, but obviously this has not come to pass. It is now 2025. If anything, we are faced with an ever-increasing burden of work. We need just as many, if not more, radiologists. So what's the reason for the failure of this prediction? Well, one may be the difference between short-term and long-term prediction. So it could be that this prediction is accurate, but just on the wrong timescale. So it's been said by Ferrier and by Roy Amara that we do tend to overestimate the effect of technology in the short term, but underestimate its effect in the long term. So maybe that's what's going on. Maybe he's right, but this will just take longer. But I think behind this, there is also some lack of understanding of what radiology really involves, and also about the difficulties in integrating new technologies into our healthcare system. That brings us on to the clinical perspective, where if you speak to radiologists and clinicians, you'll be aware that radiology involves not only image interpretation, but also clinical aspects, meetings, discussions with clinicians, and interventional procedures. And those are not going to be replaced by artificial intelligence. So from a clinical perspective, we could say, no, we don't think radiology will be replaced. But I think on this, it's important to remember a caveat, which is there's a difference between replacement and reduction, and between radiology and radiologists. So maybe radiology as a specialty will never be replaced because of these other aspects. But it is possible that, not now, but perhaps in the future, perhaps in the distant future, the diagnostic part of radiology will be significantly contracted because of effective AI. And the amount of radiologists needed for that could reduce. So whilst radiology may not be replaced, some radiologists could potentially be replaced. So the fact that the specialty doesn't disappear does not mean that some radiologists cannot be replaced. So will that happen? Kind of what's the future projection? So we move on to the workforce perspective. And the perspective of many, including the president of the Royal College, is that no, that's not going to happen, even in the diagnostic realm. There currently exists a significant shortage of radiologists in this country and globally. And this is being exacerbated year on year by the rapidly increasing volume of imaging demand that greatly surpasses the rate of increase in radiologists. So the perspective from that is no. But is this just what's happening now? Will this continue in the future? So at the symposium in Venice, I had the privilege of speaking with a number of academics from different backgrounds, different academic disciplines, and from different places, and asked them about their view on this. So Professor Filho from Brazil is an economist, and he said that effective technologies drive further demand rather than less. And ultimately, medical imaging has been a remarkably effective technology in medical diagnosis. As much as we complain about the volume of what we think is inappropriate imaging that we're doing, appropriate imaging is highly effective in the medical domain, and that will continue to increase by his perspective from a wider economic perspective. So that trend looks likely to continue. From perhaps an even wider point of view, from a sociological perspective, Professor Coeras said, it's not the powerful in society, but the disenfranchised who are uprooted by technological or other forms of disruption. And he said that radiologists do occupy a socioeconomically reasonably powerful status. And it's unlikely that radiologists, from this perspective, will be replaced by. I mean, he speaks from Australia, where doctors earn a lot. Perhaps here they feel a bit less powerful, but nonetheless, there is a formidable professional organisation of radiology from the Royal College and other groups who do lobby on a national level on our behalf to help adapt to change while protecting professional income. And finally, on a sort of historical perspective, I would also say no. So I did my medical elective in the history of radiology and wrote an essay that was published by the British Society for the History of Radiology, and gave a talk about this topic at UKIO recently, about kind of professional challenges to radiology throughout history. And it does seem that ever since the inception of radiology as a technology and as a specialty, radiologists have been grappling with professional challenges, intergroup conflicts, and technological advancements for many, many decades successfully. And it looks like that will continue in the future. And in some way, what we're doing today, kind of thinking about this technology, trying to grapple with it in advance, is a sort of that process. So many have said that this is the wrong question about this, but instead what we should be asking is, how can we improve and reposition radiology by integrating AI technologies? So this brings me to the final question: should we engage with AI, and why should we engage with AI? I think a point to note here is that it seems likely that AI is going to be introduced in some form anyway, regardless of what we choose to do. It is backed by significant investment and policy across industry governments. And as much as we would like to think that we completely control imaging, I don't think that's completely the case. The hospital is run by hospital management. We radiologists do not run the entire health service or the national government. And even in non-centralized healthcare systems, clinics and hospitals may be run by private equity groups or other groups. And so radiologists do not have full control over the entire clinical work. So AI is likely to be introduced anyway, given its promise in reducing costs. So there are different ways we can choose to approach this. And some of this it's been said to me from Harry Schreiber, who is the director of the NHS Fellowship in Clinical AI. We could choose to disengage this process entirely, but the risk of that is that AI might be implemented anyway, directly by companies approaching other clinical specialties and management. And this would affect radiology without the involvement of it, and might not be most beneficial to staff or patients, and could result in decline in our role in influence. The alternative is to engage actively. And with this, we could take AI and use it to expand radiology with greater technological capability, including, for example, what I said, multimodal integration, integrating clinical data, genomic data with imaging data, and improve our diagnostic reach. And this is akin to the expansion of radiology throughout history, from looking at plain radiography alone to now multimodality and intervention along with diagnosis. So overall, I think I would advocate that this process of transformation should be engaged with by radiologists and should be led by radiologists. Ultimately, we are the experts in medical imaging and importantly in the clinical context surrounding it. That makes us best placed to understand this plethora of opportunities, benefits, risks, and challenges surrounding clinical AI, and best placed to guide the optimal deployment of AI. And this has been said many times kind of outside the context of AI, but even within the context of AI, we must be focusing on what should we do to provide the maximum clinical value. So in summary, AI is rapidly becoming established in radiology and the rest of healthcare. It looks like it's in the future going to have significant practical and professional implications, potential benefits and opportunities, but also risks and challenges. And we need to carefully prioritize and evaluate these tools. I think there are strong reasons why this transformation should be, as far as it impacts imaging, should be led by radiology. We should embrace our roles as experts in this clinical domain to guide its safe and effective deployment. And for any registrars interested in getting involved in this area, there are multiple avenues, including the fellowship, but also projects, meetings, and resources. Okay. So these are some of the references that I've used. And I'd like to thank my funding bodies, colleagues in the department, and also my, in particular, my supervisor. So thank you for listening. I'd be interested in